We should have something that says acute kidney injury. So good, so far so good? Okay, let's just get this out the way. Rightful, acute kidney injury, whatever the hell you want to call it. Make sure you know that this used to be called acute renal failure, right, y'all? It's acute kidney injury. You want to use the right terminology. There are 3 times. Write it at the top, like I did. There is a pre-renal, there is an intrarenal, and there is a post-renal. Write that at the top. Okay. Now, so when we look at pre-renal, I use a couple of tricks, right? Pre-renal perfusion. That's how I want you to think. Pre, P-R-E, per, P-E-R. Switch the letters around behind. Okay, so pre-renal is perfusion issues. So what has to happen for pre-renal kidney injury? Your blood pressure had to go way down real fast, because what did we say BP was? Blood perfusing kidneys. Boom. So what makes your blood pressure drop super fast? Shock or trauma, because you did what in trauma? Hemorrhage. Boom. Hemorrhaging. Trauma from and then related hemorrhaging. Shock, right? That's what it is. Shock and hemorrhaging will cause pre-renal kidney failure. Acute kidney injury. Okay, pre-renal. Now, if you ain't got no BP, you ain't got no PP. So what goes with this? Oliguria. Okay. So far, so good? All right, let's keep it moving. The next one is intrarenal. And again, we got tricks. So if you think of intrarenal, we're going to say injury. Keep the eyes together. Intrarenal injury, right? I, just like PP earlier, okay? Intrarenal injury. What injures kidneys, everybody? Think. What could cause them to shut down because it injured them? No.
Medication?
Which ones? Aminoglycosides. Give me some more. NSAIDs. Give me some more. What else y'all think? We say you gotta check it before they can have it. What else? Contrast dyes. So listen, aminoglycosides, which is your vancomycin and your little myosin drugs, right? Vancomycin, gentamicin, tobramycin, streptomycin, boom, mycin. Okay, but don't get confused. Erythromycin ain't in that group, but vanco is, and you use a lot of it. So aminoglycosides are toxic to the ears and the kidneys. Nephrotoxic, ototoxic, boom. NSAIDs, Motrin, Aleve, Advil, ibuprofen, naproxen, Anaprox. I could go on and on. Feldene. I could go on and on with a hot mess. These are toxic to your kidneys. Patients with kidney failure got no business taking them. People out on the streets take a lot, and they put themselves right in kidney failure. Okay? So this is injuring the kidney. The structures of the kidney are being damaged. Okay, let's go a little deeper. PPIs, proton pump inhibitors. They have been associated now with kidney failure. So I have a really good friend. She's talking about she on that shit for 2 years for heartburn. Wrong answer. How long you should be on the PPI for some damn heartburn? 2 weeks. You better know it. Got a little black box warning on there. You taking them longer than that, you should have seen the doctor by now. Now it's a whole other thing to take a PPI for a GI bleed. That is not what I'm talking about. I'm talking just nonsense where you go to Sam's Club and get the big ass box full and you take shit every damn day with your heartburn cell instead of getting on a treadmill and losing weight, because obesity is associated with heartburn. Okay, think it through. Everything you take has damage. It has some side effects. Everything we take. Magnesium can damage your kidneys. Go out here and drink Maalox all day, every day. You're gonna damage your kidneys. Patients with kidney failure should not have Maalox. I got news flash for you. When you get out in the real world, they're gonna give you magnesium-based products. They're gonna write it on every single patient in long-term care. All these doctors, milk a mag. You come along, and if you're stuck on stupid and parked on dumb, when the patient talking about they constipated, here, babe, to take this milk and mag, you didn't even notice that they had kidney failure written at the top of the chart. No kidney failure patient should be taking any magnesium products. Milk and mag, Mylanta, what's the other one? Maalox. Yep, don't do that. So those antacids, or whatever you want to call it, that ain't cool. Okay, so what we got so far? NSAIDs, aminoglycosides, PPIs, magnesium-based products, and contrast dyes. There's no reason why you, my love, prepared a patient with an IV and everything for contrast dye, and they have lupus or stage 3 kidney failure. The hell was you thinking? That's inappropriate. You should question that order. They can get a CAT scan, but they can't get that contrast dye. CAT scan with contrast, eliminate the contrast. What else will kill your kidneys if you're on what drug when you get the contrast dye? Metformin. You ain't supposed to have metformin 48 hours before or after. What the heck is going on here? No metformin 48 hours before or after contrast dyes. You feeling me on this? Okay, so you know, it's crazy. This is stuff happens every day. That's why folks be going into problems, okay? Now, so you get it. This is acute kidney injury. Now, what I want you to write is that most acute kidney injury is related, most acute kidney injury was related to intrarenal. And this is what it's called. Acute tubular necrosis. In other words, beloved, acute tubular necrosis is injury to the kidney from this patient taking some of these drugs or maybe some chemicals, okay? That is what the fancy name is, acute tubular necrosis. It's going to lead straight to acute kidney injury through the intrarenal process. So far, so good? Okay. Now, there's a big fancy word that will help you. Rhabdomyolysis. Rhabdomyolysis leads to intrarenal injury, which then is acute kidney injury. We talked about this in toe-to-toe. What medication could be too high and cause rhabdomyolysis? We said it in toe-to-toe. Nope. Y'all forgot just that fast. The dose could be so high. That's why you should come to toe-to-toe, because it's on your test. Rhonda, what is that medication where 80 milligrams, or if you put more than 80 milligrams, statins? How quickly you forgot. Statins, high doses of statins. And what are statins? Cholesterol medication. What's the other name for statins? Cynthia? What's the other name for them? I told y'all, let's see who's here. What's the other name for statins? I gave y'all some letters to remember. Sarah? What were those letters I told you in toe-to-toe? Katie? Nope. What were they? HMG-CoA. This toe-to-toe, that's a lot. HMG-CoA are statins. Statins in high dosages can cause rhabdomyolysis. Excessive exercise and protein intake. That's your muscle man over at the gym. They cute and all, but they about to shut down their kidneys with that dumb shit they doing. Okay, all that exercising. Because look what's going on, y'all. Keep this. What does myo mean? Muscle. What does lysis mean? Destruction. So you destroyed your muscle. Now, I don't know what the hell rhabdo mean, but for your purposes, say to yourself, renal. That's how we're going to do it, y'all. I don't know what the hell rhabdo mean. You find out, let me know, because I don't know. So what I'm saying to you is the word. You got to look at the word on these tests. They tell you what they mean. Destruction of muscle causing renal failure. Working out too much or prolonged bed rest. See, watch this. If I take my arm and do nothing with it, because I'm on prolonged bed rest with spinal cord injury and I can't move it no matter what I do, unless your behind come around and help me, this muscle is going to atrophy. It's going to waste away. Because for a muscle to stay built up, you must contract and relax. Prolonged bed rest, prolonged relaxation will break down muscles. If you don't use it, you'll lose it. When it comes to contracted muscles, working out too much, or, you guys know this, neuroleptic malignant syndrome, or malignant hyperthermia, in which your muscles stay contracted and never relax, you're still gonna break down that muscle. So rhabdomyolysis is a complication of malignant hyperthermia, neuroleptic malignant syndrome, and of course, prolonged bed rest and excessive exercise. That's what it is. Okay, now, we have a patient that has acute kidney injury from rhabdomyolysis. What should we do first? What is the first nursing action? Ola, what do you want to do first? Exactly, hydrate. Don't make me wait that long. Allow. You got a tape to do. Hydrate. Hydration is the first nursing action for rhabdomyolysis. Okay, all right. You're doing the doggone thing. Now, we had one more. He had post-renal injury, post-renal failure, post-renal issues. Think about it. Post-renal means your blood pressure was fine. You actually perfused your kidneys. They actually made urine. Post-renal. They did all that. It happened post-renal. They functioned, they perfused, they made urine. Post-renal. O for obstruction. Now the urine can't get out. Post and OBS, obstruction. So now the urine can't get out. Now you said it earlier, what is it? What kind of example is this? When can the urine not get out? What did you say, Eddie?
Kidney stones.
Kidney stones. That's an example of post-renal obstruction. Kidney stones. Enlarged prostate. Cancer. What if there's a big old tumor in the way? Can't get out. Enlarged prostate. So far so good, y'all? All right. Okay, boom. Now, here's the deal. You have those three types of acute kidney injury. I need you to know with the first one, which was pre-renal, you have oliguria. With the second one, you actually still make urine. You don't have oliguria yet. You might get it later, but you don't have it yet. So no oliguria. Make sure you know that. The last one, you have something called anuria. A before word? Without any P at all. So far so good? Okay. Now look at the rifle. Look at the word rifle. Each one of these are stages of acute kidney injury. The R, the I, the F, all this crap, right? You got a few more things to write on this. Where it says R for risk, I want you to, when it says first stage, I want you to write down. Matter of fact, you ought to tell me. What's the first sign of kidney failure? What'd you say? Cheek color urine? No, that's glomerulonephritis. We did that toe-to-toe. What's the first sign of kidney failure? Acute kidney failure. It's a lab. Creatinine. That's what you better put first. First sign is increased creatinine. That will happen first. You must know that, everyone. First sign of kidney failure is an increased serum creatinine. Okay. Second sign. What can't come out if you can't pee? So under the second stage, now put high potassium, just like I did. Boom, high K. Only got one thing under each one. Y'all cool? Okay, now we got a third stage. Now I want you to put high BUN. Now we have a fourth stage, and that's where you have oliguria. Pay attention to the last one, the E. It says end-stage kidney disease. I need you to know, if you look at it, complete loss of kidney function for 3 months or more. Now we're in end stage. Because here's what you gotta write, you gotta write it real big. 99% of all AKI is reversible. You will recover. So most AKI is recoverable, right? It's reversible. You will recover. Your kidney function will return when we fix the problem. A very small percent will be so damaged that they can't recover, and then you slide into something called end-stage renal disease. We don't make that assessment unless it's been 3 months. If it's been 3 months, boom. You ain't made no pee, oh shoot, she got kidney damage for life. Now you need dialysis. Now, it takes a full year, write it down, takes a full year for your GFR to return to normal. What's GFR? Glomerular filtration rate. Okay, let's keep it pumping. Next page, quick. Now, the next page says acute kidney injury, signs and symptoms. You have 3 phases. Keep in mind, this is reversible. So this is not chronic kidney disease. This ain't Big Mama now. This is somebody else, okay? So if you look to the title, acute kidney injury, now it's talking about signs and symptoms. For the oliguric phase of acute kidney injury, be careful about what you learned in school. It wasn't wrong, it was just maybe a little incomplete. What did we all learn oliguria is in school? Less than what per hour? 30. Well, that is good, but it ain't great. So less than 30 cc's is true. Less than 30 cc's per hour is true. But I need you to know another number. Look at it. Less than 400 cc's in a day. Highlight it. If it's a little one, pediatrics, can't forget the little ones, you're going to have a different kind of calculation. And this is true for all kinds of things, pediatrics. For calculating what dosage is and all this stuff, we say for the baby, 1 cc per kilogram per hour. Make sure you know your pediatric issues. 1 cc per kilogram per hour. So if this is a baby, it's a little different. Okay? Now let's look. I want you to highlight the word cast under that urinalysis, and remember that when you see cast on a urine, the kidneys have been injured. Usually kidney stones will do it. Okay, so cast. Everybody see it? Okay. What color is the urine if that specific gravity is what it says? What color is the urine? Is it dark or pale?
Dark.
You don't know your specific gravity, obviously. Specific gravity on this patient, if you look at it, is it low or high? It's low. Low specific gravity equals pale urine. This patient's urine is pale because there was no chronic issue. Right now, we're still pale. Know your specific gravity. You already know metabolic acidosis because what did you retain? Uric acid. Remember, you were supposed to excrete that waste. You did not. You can't pee that much, so you are maintaining or retaining uric acid. Uric what? Acid. What is that? Acidosis. It's not a respiratory issue, it's metabolic. Boom, highlight it. Okay? All right, now, hyperkalemia, but then something really weird. Hyponatremia. I promise you, you gotta know that. High K, low sodium, they're opposites anyway, we can roll with it. They're opposites. High K, low sodium, they are opposites. Okay? Now, if you look at the diuretic phase, when this patient starts to recover, we've got to get rid of all that water that they retained. When you get rid of all that water, when you keep peeing, what are you also going to make go down? There you go. This diuretic phase, I need you to put in really big letters, low K. But when you get rid of water, you're also getting rid of salt. So we have a low sodium. Now we're at a point where both of them are low. Because every time you get rid of water, water and salt are married. So the more you pee, the more sodium you lose. The more you pee, the more potassium you lose. Making sense, isn't it? Okay, so potassium and sodium are both low. What controls your blood pressure? You're getting rid of a lot of it. So what's your blood pressure? Highlighted, it's on there already. Now you're getting rid of your waste, your BUN and what? Creatinine. So they're lowering, they're getting better. Doesn't it make sense? Okay, now, let me tell you what I need you to write so you got a clue. I just told you about osmolarity. Now you are peeing. So you are doing something called, and the diabetic does it too, osmotic diuresis. Osmotic diuresis. Because would you agree that when you weren't peeing, you had a fluid volume overload? Now you're getting rid of the water. Diuresis, osmotic diuresis. All that water got to come off. Osmotic diuresis, that's what that phase is, diuretic phase, osmotic diuresis. Now you go to the bottom, you're recovering. Just right, it takes up to a year. If it's been 3 months and your kidneys don't return, what do you have, everyone? End-stage renal failure. Next page, chop chop, let's go.